Hello, everybody. This is Dr. Mike Kaufman, State EMS Medical Director with the Indiana Department of Homeland Security.
And this is Craig Kinney, the State EMS Director. We're here today because of our capabilities. We were unable to do a teleconference, so this presentation is intended to give you valuable information as we deal with the COVID-19 crisis.
Thanks, Craig. The presentation we're going to give to you guys today really just is here to capture the current state of this public health emergency. We're going to try to address all of the areas that this office has been receiving as far as questions go, and try to tell you a little bit more about the current state of this new public health emergency as it continues to unfold. So most of you have already probably received a significant amount of information about coronavirus, but I wanted to at least touch upon what we're actually dealing with, folks. This is an RNA virus, okay? This is a large family of viruses, and the reason it's called a coronavirus, corona means crown. When you look at this virus under a microscope, it actually looks like a crown, as you can see here in this picture. And this is not the first time that we've seen coronavirus emerge as a public health threat. Y'all may remember the Middle East Respiratory Syndrome, MERS, or this previous episode of Severe Acute Respiratory Distress Syndrome, or SARS, that was seen. And coronaviruses in general are a common virus that causes upper respiratory illnesses like the common cold. But this in particular is a new strain that we have never seen before in the human population. Reporting numbers worldwide, and folks, this is a moving target. This changes hourly, so I would urge you to continue to check other data sources, but this is a common source that many people are referencing, showing that we are rapidly approaching more than 500,000 total confirmed cases worldwide. And I use that word confirmed because there's likely a significantly greater number of positive individuals out there, but because of our worldwide lack of testing, we just don't know the full extent. If we drill this down to look specifically at the United States, this number has expanded dramatically just over the last 72 hours. We are now over 70,000 confirmed cases, and the data I'm representing here was pulled this morning as of 7:30. So this is a rapidly spreading public health emergency that we all need to be super vigilant and watchful of in our own areas. If we look at Indiana, and this is data that was reported as of this morning at 11:59, we are at 645 positive cases, 17 total deaths, and 4,651 individuals tested. At the regional map here to your left, you can see the vast majority of these cases are going to be centered right here in District 5 in Indianapolis, with another significant cluster occurring up in District 1 in Lake County. That has a lot to do with the direct proximity to Chicago. Like any other new or novel infection, you can expect this to continue to expand rapidly in areas of high population density. So also be watchful down there along districts 9 and 10, as those are also population centers where numbers will be continuing to expand on a daily basis. I wanted to share with you how this is looking from a nationwide perspective at deaths. We're currently seeing mortality rate for this illness upwards of 3%, but this is ever changing depending upon what region you're looking at, what country you're looking at, and so forth. I think the take home from this message is that we are still on a rapidly upward trajectory here in the United States, as death rate by country is illustrated here. Other areas where the virus initially emerged, such as China, South Korea, Japan, due through containment measures, their death rate has seemed to level off, but note that it has not started going down. If we look at U.S. deaths alone, almost every projection is still on the upward climb. Indiana has not been included in this graph because they have not yet experienced 10 deaths, but that number changed as of today. So we can start tracking this data showing deaths by state, and the New York Times is an excellent place to reference this data. So as I mentioned before, this is a new public health emergency that's just emerging. For the technical side of this, it is an RNA virus. It is part of the coronavirus family. It is a similar infection to that which caused MERS as well as the previous SARS outbreak. And the one thing we need to keep in mind is that as this virus is rapidly replicating within humans, it's also seen mutations of this, which is going to complicate matters even further. Mutations will significantly impact the infectivity or virulence of this, as well as the mortality rate that we're seeing. And this likely explains why we're seeing higher mortalities in some areas as opposed to others. So this is something that we'll need to keep a very close eye on as this infection continues to spread. How does this virus transmitted? And we've covered this before, but I always like to review this because we have to protect ourselves first. COVID-19 transmission occurs via large droplets, so we call that respiratory droplet transmission. This is thought to occur within an area of approximately 6 feet around an infected individual. This is typical for respiratory viruses like influenza or other respiratory illnesses. Transmission via large droplet can be prevented by using a standard surgical style mask. So that is the current recommendation by the CDC as well as the World Health Organization. I want to briefly address surface transmission because there is some data that have started to look at surface transmission on objects, inanimate objects. That's called fomite transmission, also called fomite to face. This looks at transmission on objects such as tables, doorknobs, laptops, tablets, and all sorts of other inanimate objects. I think this often gets overlooked, but it is incredibly important. So this would potentially work as if an infected person were to cough or sneeze and emit large droplets onto their hands or onto solid surfaces. Those droplets will settle on those surfaces and will create a thin film of essentially infectious coronavirus. That virus can also be shared and shed via nasal secretions. Depending on the type of surface, it's been shown that this virus can last for several days if not appropriately decontaminated. So the message here is that it is critically important to wash your hands, cover your cough, and disinfect surfaces on a routine basis. How do we block contact transmission? Well, any effort to limit the spread of virus must block this mode of transmission. The chain of transmission that we briefly touched on can be disrupted in a variety of ways. The first and foremost of which is regular cleaning of environmental surfaces. Typically, that's going to be done with any standard type of commercial disinfectant, but particularly with those containing at least 70% alcohol. Hand hygiene also becomes critically important, so remember to wash your hands frequently. And very important to mention is avoid touching your face. The average person does this 11 times per minute. Don't forget your medical equipment, particularly your laptops and your tablet computers that your patients routinely have to touch when they sign your charts. A recent study showed widespread deposition of COVID-19 in one patient's room, but fortunately this seems to be removed again by cleaning with commercially available disinfectants. What is airborne transmission? Strictly speaking, aerosols refer to particles that are suspended in gas, such as droplets in the air. Airborne transmission of infective agents occurs with other types of infectious diseases such as TB, measles, and chickenpox. An appropriate PPE, such as an N95, will prevent airborne transmission. A recent study of SARS-CoV-2 or COVID-19 demonstrated the ability of the virus to persist in aerosols for hours, making aerosol transmission very plausible. The bottom line on this is that this is probably not the primary mode of transmission, but airborne transmission needs to be considered, especially when you, as an EMS professional, are engaged in aerosol transmitting procedures. That's airway suctioning, administering nebulizer treatments, and such. And we'll talk about those more in just a few minutes. The last thing I want to mention here on the epidemiology has to do with something you've heard a lot about called the R0. This is the average number of people that can become infected when an infected person transmits the virus to them. The R0 less than 1 means that an epidemic will burn out. If the R0 is equal to 0, the epidemic will continue to spread at a steady but manageable pace. If the R0 is greater than 1, the epidemic will eventually increase exponentially. Our current estimates for COVID-19 put the R0 somewhere around 3. Maybe as low as 2.5. But what that means is that this virus is going to spread exponentially. Interventions like social distancing and staying at home and hand hygiene will decrease the R0, but for the foreseeable future, this highly infectious illness will continue to spread. As an example, to further illustrate this, on the Diamond Princess, the cruise ship that was highly infected, the R0 was upwards of 15. So this illustrates that cramped quarters with inadequate hygiene will further act to spread this epidemic. When does transmission occur in a person that's infected? We've now learned that asymptomatic transmission, that means people who have the illness or have the infection but don't yet know they're ill, they are infectious. This can occur in up to 10% of people. Symptomatic transmission occurs approximately 8 days following the initiation of the illness. We found that the median incubation period is somewhere around 5.1 days, but those who have been exposed will typically develop symptoms in 11.5 days. So from a statistical standpoint, that means that we can be relatively sure that less than 1% of cases will develop symptoms after 14 days of active monitoring. That's why the quarantine period currently stands at approximately 14 days. What are the symptoms of COVID-19? The vast majority of symptoms are still respiratory. So runny nose, cough, sore throat, like you've got a bronchitis. Less commonly, gastrointestinal symptoms occur. That means in about 10% of people, they'll also experience diarrhea, nausea, and or vomiting. Fever can certainly be there, but in folks who potentially are older or have comorbidities, they may not mount a febrile response. So absence of a fever does not exclude COVID-19. Anecdotally, folks, we've seen patients test positive who presented after a traumatic motor vehicle accident, after a stroke, or simply a complaint of feeling weak. So be diligent and wear your PPE when indicated. I want to provide you next with some information, and I'm going to start with the folks that are usually the front line of our emergency system, and that's our public safety answering points, or our dispatch communication centers. EMS and PSAP should be actively asking questions and pre-screening all individuals for potential COVID-19 infection. Each public safety answering point should seek involvement of their EMS medical director to expand this additional questioning, as well as giving them the ability to provide advice and guidance to patients, as well as to EMS provider agencies who are responding. Public safety answering points should also be providing as much advanced notification as possible to the EMS provider agencies. PSAPs or EMD centers should ask these modified caller queries of all patients who are calling for assistance. Again, information on possible persons under investigation or persons of interest should be immediately communicated to EMS clinicians before they arrive on scene. Having said that, as an EMS provider, you should approach every patient as one that's potentially infectious. Use your medical director to work with your own agency as well as with the PSAPs and communication centers for assistance. Some of the additional questions that should be asked from public safety answering points include histories of fever, cough, shortness of breath. And I do want to mention that while travel questions were initially part of the call queries, we're now seeing community transmission, so it's no longer needed or necessary to ask questions about travel. Specific individual questions might include, do you have a fever? Are you hot to touch? Have you had chills? Do you have a persistent cough? Or have you had any new respiratory symptoms such as sneezing, coughing, or wheezing? Likewise, EMS providers should approach every patient with some degree of modified scene safety and assessment. Do a room scan before entering the scene, and potentially remain 6 feet away from the patient and or their family members until you have an adequate history. Potential questions there would be, is anyone coughing or having respiratory distress? Does anyone have a fever or recent infection? Have you had any contact with a known positive patient of COVID-19? And ask yourself the question, is the location you're responding one of high risk, like an extended care facility, jail, or assisted living? I also want to recommend that you limit the number of responders going in for that initial assessment. Whereas at one point in time, you might have dispatched an ambulance, an engine, as well as a supervisor, limit that exposure to one person until you've adequately determined that the scene is safe. Consider having the patient exit the room or location on their own if feasible, and, which we'll talk about a little bit more later, avoid any aerosol generating procedures as much as the patient's condition will allow. One of the things that we're also advocating for all EMS provider agencies statewide is to develop a protocol for provider-initiated non-transport. This essentially means that if a patient met specific screening criteria, you could offer to them to not take them to the hospital, but suggest other ways that they might seek medical care. This would typically be done through a screen looking for patients that have abnormal vital signs, as I've listed here in the yellow box. These folks still need transport for further assessment. But if a patient were to be identified as not having symptoms, or what we might call a worried well, we could recommend, under certain conditions, that they not be transported to the hospital. This type of protocol would be triggered at a point in time when your EMS dispatch volume exceeded your ability to transport those patients that were sick or needed medical assistance. This should be put together with guidance from your medical director and guidance on how busy or how stressed your own EMS provider agency has become. Currently, most EMS provider agencies are seeing standard volume in terms of calls and dispatches, but as we're expecting a greater number to become infected and a greater number to be critically sick, we could see a point in time where our EMS system is stressed beyond our ability to transport every patient that calls. Please work with your medical director and medical team to further develop potential non-transport patient protocols. I want to briefly touch on PPE before turning things back over to Director Kinney. The recommended PPE is going to be some type of surgical face mask or N95 respirator. Eye protection is critical. A single pair of disposable patient exam gloves and an isolation gown. Remember to tuck the sleeves of your isolation gown into your gloves. That's a common point of contamination. Likewise, you should know how to don and doff your PPE in a way that limits your infection potential. Remember, disinfect your hands after you've had patient contact before removing your gloves, and then again so after you removed the rest of your PPE. I want to make a special note about our drivers of our ambulances. If you provide direct patient care, you too should also be in recommended full PPE. If at all possible, make an attempt to isolate the driver's compartment from the passenger or patient compartment in the back. If there's a definitive separation of those areas, whoever's driving should remove their PPE, disinfect their hands, and can enter the driver's compartment. If the transport vehicle does not have an isolated driver's compartment, whoever's driving should remove their face shield, goggles, gown, and gloves, perform hand hygiene, but continue to wear some type of face mask or respirator during the remainder of the transport. I want to also, again, emphasize that all personnel should avoid touching their face while working. For additional information on standard precautions, I'm going to refer you to the CDC website. They have very detailed guidance on appropriate level of PPE, as well as how you should disinfect your ambulances and how you should discard your potentially contaminated PPE. Aerosol generating procedures. You should work with your local medical direction to develop policies to avoid any and all aerosol generating procedures. These are going to include things such as bag valve mask ventilation, oropharyngeal suctioning, nebulizer treatments, CPAP, BiPAP, intubation, and even CPR. All of these procedures have been shown to produce a significantly higher level of aerosolized viral particles. When at all possible, avoid performing these procedures in the ambulance and during transport. When absolutely necessary and possible, the rear doors of the ambulance should be open and the HVAC system should be fully operational. But again, work with your local medical direction. We have provided additional guidance from IDHS that you can adopt locally for your protocols when working with your medical director for this guidance. Again, all aerosol generating procedures should be avoided when patient condition allows, and those again would include BVM, suctioning, intubation, neb treatments, CPAP, and CPR. Because PPE levels are running critically low, we have to do everything we can to preserve PPE. That includes N95s. For those EMS provider agencies that have access to and utilize SCBAs, those are an option because they can be reused and cleaned on a regular basis. Surgical face masks are an option unless you're doing aerosol generating procedures or have very close contact with your patients. We need to prioritize the use of N95 respirators. It is currently possible to reuse N95 respirators under specific conditions where those are not becoming contaminated or soiled on a daily basis. Please consult your local medical direction as well as local guidance on the best way to preserve and conserve PPE, but know that the supply line of these items will be limited for the foreseeable future. The CDC has published guidance on this. Remember to clean your hands with soap and water. And note that using an N95 can be done repeatedly when a face shield or some other protectant is used along with those devices. If approved by your local medical director, alternative means of screening patients like telemedicine are also acceptable. Remember to only take essential equipment inside when you're approaching any patient, including that one with a suspected COVID-19 infection. And tailor your assessments to focus on priority symptoms, such as listening to breath sounds. Proper adherence to the currently recommended infection control practices, including wearing all of your PPE, essentially means that you have not had a significant exposure. For those that are not directly participating in patient care, also know that you are not at increased risk of exposure to COVID-19. Additional information on your own exposure can be found from the CDC website, and I've included that reference here. Likewise, if you feel that you may have had a potential exposure, you can call the Indiana State Department of Health testing hotline at the number I've provided here. They have persons available that can provide you with real-time guidance on helping to assess your exposure. I also want to mention the CDC also acknowledges that many provider agencies and healthcare professionals just simply don't have the staff to take folks out of service for extended periods of time. If you have an exposure and you are not wearing your PPE, it is advisable that you may continue to work when wearing a face mask. But note that if you are wearing your PPE, you are considered safe and you may continue with seeing patients and active duty without any further interruption. The last thing I want to mention has to do with testing. As we know, there's been a statewide shortage of available tests. EMS providers are reporting increasing numbers of personnel out on quarantine. Let me remind you that asymptomatic personnel do not need testing. When possible, patient source testing should be performed to help dictate your guidance. Indications for testing symptomatic EMS providers and other public safety professionals would include that if you potentially exposed multiple high-risk persons, for example, maybe you walked through a nursing home or had interaction with several patients at an extended care facility. If you're symptomatic, you should likely be tested. Additionally, if you exposed a large number of persons within your own public safety agency to the point where you might have to close down or go out of service, you should also be seeking testing. Follow your local agency's standard operating procedures, consult with your occupational health provider for additional guidance or your own primary care physician. Note that all testing requires a physician's order, and I would start by having you check with your local hospital. You can also visit the Lilly website. Just a couple days ago, Lilly offered expanded testing for public safety professionals. I would urge you to visit their website for further information on testing.
Thank you, Dr. Kaufman. We're going to move on to some of the EMS operations and give a review and also see different areas that we're receiving a lot of questions for. First of all, the governor did issue a stay-at-home order, and with that order, he delineated essential government functions. EMS does fit squarely in that, and so EMS should continue. And we also advise that you should have a plan for who you need to keep both personnel and ambulances operational, because you need those additional support personnel as well, such as maybe fleet mechanics, sometimes supply officers. Try to minimize the number of people that are needed, but if you need them, they are performing an essential function. So the first waiver, all of our waivers are currently active. The first general waiver addressed as part of a COVID response. A provider organization could essentially strip an ambulance and designate it as a response vehicle. You can do that. Just remember, you do have to keep airway management equipment on there. And also, any ALS patients that need ALS care must have full ALS capability. The second waiver that we issued covered several points, and it's important to remember these. First of all, the expiration dates on medicines and equipment. So sometimes if we follow CDC guidance, there are expired items that you can continue to use during this public health emergency. The requirement for transport by ambulance has been relaxed for non-critical patients. So for instance, if they do truly need an ALS ambulance, they need to go by ambulance. But if they are what we would consider BLS or lesser, then you can consider, with medical control, your medical direction approval, you could consider other alternative transports, such as, a department SUV or something to limit that exposure. The emergency care equipment has been waived from basically the compliance of stocking the minimum numbers, including PPE, and because of the fact that restocking may be a challenge. And the 24/7 rule is relaxed if there is not sufficient staffing and it's related to the public health emergency. So if people are calling in or quarantined, then that could create this waiver. And finally, we addressed basically the requirement that an EMT is required to have a paramedic response or an advanced EMT response, and said that as long as you have the actual certified provider, the advanced EMT or the paramedic doing patient care, then the driver can be essentially anyone that has a driver's license, but preferably an EMR would be an appropriate substitute, but you don't have to have that second EMT on that ambulance. The waiver that was most recently released, and all of these waivers are on our website if you want to review them in detail, does cover also the transport for a paramedic response, and creates a specific exception for interfacility transports. Specifically, we're considering most likely hospital to hospital. If there's a staff shortage because of public health emergency, then we can substitute for a paramedic. You could put a nurse, a physician, or a physician's assistant in the back of the ambulance in place of that paramedic. You would still need to have an EMT on there as well. And if your medical director does deem appropriate personnel, you could also consider like a nurse practitioner, something of that nature, because the intent of this waiver was to open it up some flexibility if the hospital has better staffing than the ambulance does. And so this is an important one we've been dealing with today, and I expect guidance to go out in a little bit. We've had a lot of requests where facilities are not willing to release information to EMS providers on patients they transported, and we're getting information that some hospitals have adopted a policy. We are not going to notify of positive COVID-19 testing. And we need to go back to the Ryan-White Act. I believe if you look at that act, then SARS was included specifically. And as Dr. Kaufman so well explained, this coronavirus is considered a SARS type virus, so it falls within that. And to that end, the Office of Civil Rights, the OCR, which is part of Health and Human Services, which regulates HIPAA and privacy, has issued guidance 2 days ago that emergency responders maybe when they are at risk of an infection, they need to be notified by facility. We are working with Department of Health. We hope to have guidance on our website and to send out later that will help clarify this, but essentially the facility should be providing access to positive notifications. I would note it doesn't guarantee that they can release all patient information, so they may just tell you that a transport tested positive, and if there is aerosol generating procedures, they should let you know. Again, that guidance should clarify when we get it released. Looking at our other operations changes, it's important that we keep up with data. Data is helping quite a bit. Dr. Kaufman is pulling that, and that helps with trending. And Image Trend has created a COVID-19 worksheet. This worksheet may be helpful for your crews to do on-scene assessments, but also is helpful for you to track that those assessments are being done. So if you're part of the state system, you can, it is on there, and you can require your staff to do that, and it would be appreciated. If you have a private version of Image Trend, you would have to activate that through your vendor. So continue noting things such as PPE usage, and then a primary impression should always still be the chief complaint while you're there, shortness of breath or fever. But we just got guidance that with NMSIS reporting, they are tracking, and they would like to see a secondary impression when you believe there is exposure. And you see on your screen that there are 2 codes there that you can use that would indicate a suspected exposure to a viral communicable disease or other coronavirus listed. I apologize, a third one, encounter for a biological agent. Any of those 3 they are going to track if you do that as a secondary impression. So that's very key. If we can start flagging our data with that, that will help both internally so we can get more data reports out, but it is also going to help on the national level as they are doing trending. By the Governor's Executive Order 2009, all state certifications that expired during the public health emergency were extended till May 22nd. We have gone in at CADIS and we're able to update those that had not already recertified, and they should have the new expiration date of May 22nd of 2020. And it is important to note this does not toll every quarter after this, or even for this individual that was extended to certify until May 22nd, they're still going to stay on a March 31st cycle. And so people need to keep up with their continuing education as much as possible. If EMS providers are still seeking to certify, one of the waivers include that we will accept electronic verifications in lieu of having physical signatures, since we know those would entail face-to-face contact and more risk of exposure. National Registry of EMT has come up with an innovative idea of provisional certifications if a candidate has completed a course of instruction and they passed a cognitive or written examination but are unable to take the practical or psychomotor examination due to the fact they are not being offered. And states are addressing this state by state. Honestly, several of them have said they don't have that authority. We did issue in waiver number 3 that we will accept the provisional certification, and we have regulatory provisions for a temporary certification, and we will issue a temporary certification for 120 days. In order to use this, you would submit a National Registry EMT provisional certification, that paperwork, with an application for reciprocity with the state of Indiana, and you will get that temporary certification for 120 days. Once we're past 120 days and hopefully resolving or ending this public health emergency, then they would need to take a practical examination and complete their permanent certification. EMS education can continue. We've had a lot of innovative places that are doing distance or webinar, other options like that. So it's at the discretion of each training institution. The portfolio requirement is not waived. We have a lot of questions. We realize there is, with a psychomotor, you're going to at least have 2 people, but there's innovative where you could technically do that by maybe screening it or otherwise. That's up to each training institution. If you do not find a suitable alternative, then the option may be just to postpone your class, and we would honor that as well. EMT practicals have been canceled at least through April 7th for the duration of the stay-at-home order. Just as a precursor, if that stay-at-home order is extended by the governor, then we anticipate we would cancel those EMT practicals during that period. The EMT cognitive or written testing is done through Pearson VUE or Ivy Tech. Currently, all Ivy Techs are closed. There are Pearson VUE testing centers, and we did get notification that people tested yesterday. That was thanks to the National Registry advocating that this is essential for workforce creation. And so if candidates are just waiting to do their cognitive or written examination, they should log in their National Registry EMT account and look at registering for a cognitive exam, and they should see options that may be available in Indiana.
All right, folks. Thanks, Craig. So some things that we'd like you to know about and help us have better real-time information about this crisis. By now, all of you should have access to the EM resource application. This is disaster management software that was purchased by the State Department of Health some time ago, and we are asking EMS to, every EMS provider agency to have an account in EM resource. You should have already received login information, and again, this would be going to one individual at each provider agency. It is not necessary for individual paramedics or EMTs or first responders to have a login for this. But every EMS provider agency in the state is listed in this, and it allows you to report the status of your workforce, your personnel, your PPE levels, ventilators, and gives the State Department of Health as well as the Department of Homeland Security real-time insight into the operational status of our entire EMS system. What you're looking at here is the dashboard that shows PPE levels amongst the transporting EMS provider agencies. This is categorized into a red, yellow, or green level to give us just a quick snapshot at what your PPE levels look like. This is another screenshot showing the status of provider agencies. And you can see here that the information we're asking is whether or not you are an ambulance provider agency. Do you transport patients? What your staffing levels are, the number of ventilators that you have available, your ambulance availability, your PPE status, and then a 24-hour contact number, as well as a name, email address, and phone number of someone in your agency that would be the primary point of contact. If you have not yet signed up or are logging your daily information within EM Resource, please reach out to your EMS district manager immediately. It's important that we have day-to-day visibility on the operational status of our entire EMS system. So again, we're asking all EMS provider agencies to update their status daily at a minimum. If you have requests for additional PPE, simply logging your status in EM Resource is not enough. You need to report your request for additional PPE through your local emergency management agency. I also recommend that you notify your local health department. The emergency management agencies are collecting PPE needs from all of public safety and will then submit a formal request through Web EOC, which feeds information directly to our statewide Emergency Operations Center. We're coordinating with PPE stock that might be coming locally, as well as stock that we might be receiving through the Strategic National Stockpile, and it will be distributed to those in the most greatest amount of need.
So one of the innovative ideas, and I applaud all of EMS for being innovative as we've looked at this public health emergency, And Indianapolis right now is currently looking at a plan for a metropolitan area and their regional operations center to come up with an EMS resource hotline is our idea to assist them. So while this is an Indianapolis metropolitan venture currently, this is something that other regions can look at and could possibly be statewide, and that's why we want to flag that. And so basically the idea is we need to have a good balance of, if new patients are coming into a facility, we got to have space for them. And we're going to start seeing surges, and they may not all be the same. For instance, if I tracked a few days ago, I know Greenwood had a much higher population rate than, say, the north side. Well, there may be a need to transfer patients from one area to another area. And the idea is that we can go ahead and pass those things along.
Yeah, Craig, I'd like to expand on that for just a minute. Folks, we're kind of in what I like to call the tsunami effect phase of all this. So we know that a large surge of infected patients that will need to go to the hospital, will need hospitalized, will need a ventilator and ICU, that's coming. But just like before a tsunami hits a beach, water's flowing out from the beach right now. So you've probably all experienced a decrease in your day-to-day volume. Hospitals are canceling elective procedures, doctors' offices are canceling appointments, so EMS volume has been down. But when the surge of patient hit, when that large surge hits our state, all of our provider agencies are going to be needed to hopefully maintain a steady flow of patients. That will require our 911 providers to continue moving patients into hospitals, and it will also require our private EMS provider agencies to be offloading those hospitals with discharges or transfers to alternate care. Some folks won't require acute care facilities, but they might still need hospitalized for oxygen, so they potentially will be moved to off-site locations that are currently being set up. We are currently in discussions with the State Department of Health as well as the Indiana Hospital Association to further socialize and develop this surge plan. Like Craig mentioned, we have to put together a surge plan that gives all those necessary resources that EMS can offer to those that have those questions. So this EMS resource hotline, it's not intended to be a dispatching or a center, but it will be available to provide real-time guidance to hospitals, healthcare systems, other state agencies that need to know how to best utilize EMS. So my point here is, folks, be ready. The surge is coming, and we need each and every one of you to help. Otherwise, our EMS and our healthcare system will not be able to handle the surge.
So if we look at this slide, this kind of reiterates, and I think that is an important point. Dr. Kaufman states that I think sometimes there are people that don't want to do these inter-facility transports. It's vital that we have this occur so that way we can move people efficiently and also transfer that surge around. And so coordination is going to be important, and that's why through both a collaboration with the Fire Chiefs Association and our EMS office, we are working to staff an EMS resource hotline that would basically then take requests from hospitals, and we would then pair it with an available provider. So our idea is that we aren't specifically dispatching it, but we're coordinating that resource, which is a function of the EOC. And so that's why we have our district managers are reaching out, and we need to know your ability and willingness to help, because that is so crucial for handling this surge capacity. So these guidelines are additional information available for you, and as always, the Indiana State Department of Health has a great website that has a lot of the same resources CDC does, and even Homeland Security. On our front web page, you can find a link with all of our current guidance and everything there. So from Craig Kinney, I thank you all for what you're doing, and I encourage you to stay healthy.
And again, folks, for us to survive and make it through this epidemic, and in particular, the surge of patients that will be presenting over the next 4 to 5 weeks, we all have to stay involved. We all have to do our part. I can't thank you enough for being part of our system of pre-hospital care that we call our EMS system here in Indiana. It's going to require all of us to participate, whether 911 provider or private provider alike. And we have to do so in a way that's collaborative, cooperative, and allows us to function as one large EMS system serving Hoosiers all across the state. Thank you very much for your dedication, for your compassion, and thank you very much for being there every day for Hoosiers in the state of Indiana. Thank you.